Hi guys, it is page number 7, note 6 of respiratory pathology, pneumothorax. Accumulation of air in the pleural space is called as pneumothorax. There can be dyspnea. Okay, सांस लेने में दिक्कत हो गया, uneven chest expansion will be there, chest pain will be there, low tactile fremitus, hyperresonance. When we tap, you get a hyperresonant note and diminished breath sounds. No air entry, no. Therefore, there is diminished breath sounds all on the affected side. There can be many types of pneumothorax: primary spontaneous pneumothorax, secondary spontaneous pneumothorax, traumatic pneumothorax, tension pneumothorax. So, primary spontaneous pneumothorax is due to the rupture of a apical subpleural blood-borne cyst. What happened? It is a primary spontaneous pneumothorax. The patient had no other problem, no other pathology. There was an apical subpleural blood-borne cyst that looked innocent, but it ruptured, leading to a pneumothorax. It occurs more frequently in tall, thin young males and is also associated with tobacco smoking. What about secondary spontaneous pneumothorax? It is not unlike the primary. Secondary spontaneous pneumothorax is due to some underlying pathologies there within the patient. The patient has got some disease. What could be the diseases? It could be due to emphysema. The rupture of an emphysematous bullae can lead to a secondary spontaneous pneumothorax. Marfan syndrome. If the patient has got Marfan syndrome, it can lead to secondary spontaneous pneumothorax. It could be due to some other infections. Okay, then mechanical ventilation with the use of high pressure can also lead to barotrauma. So this barotrauma is a disease-like condition for the lungs, finally leading to secondary spontaneous pneumothorax. Okay, now we go on to traumatic pneumothorax. What do you mean by trauma to the chest? Okay, some kind of trauma occurred to the chest and finally leading to pneumothorax. What could be the trauma? It could be due to a rib getting fractured. It is called as a blunt trauma, or it could be an intentional penetrating trauma like a gunshot wound or an iatrogenic trauma. हमने डॉक्टर्स ने किया a trauma. What are they? Central line placement. When we place the central line, there occurred a pneumothorax. We ruptured we accidentally entered the tip of the lungs, and then lung biopsy. Okay, can cause us pneumothorax. Barotrauma due to mechanical ventilation finally leading to pneumothorax can come here also. These are the trauma related pneumothorax. What about tension pneumothorax? It could be due to any of the above. Okay, reason कुछ भी हो, mechanism एक ही है. Air enters the pleural space, उसे वापस नहीं जा सकता, but can't exit. Okay, increasing amount of trapped air inside can lead to tension pneumothorax. What will happen to the trachea? एक lung बहुत ही बड़ा हो रहा है, इसलिए ट्रकिया deviates away from the affected lung. What will happen? Increased intrathoracic pressure. Mediastinum gets displaced. If the mediastinum gets displaced, there can be kinking or obstruction to the inferior vena cava. Inferior vena cava was taking blood from the body back to the heart. Therefore, venous return got affected. Okay, cardiac output low हो गया. Finally leading to obstructive shock. Obstructive shock हो गया because of obstruction, heart is not able to pump out. Therefore, there will be hypotension, heart trying its maximum leading to tachycardia. Then, what about jugular venous distension? Yes, there will be venous distension, need immediate decompression and chest tube placement. Okay, so this is the topic. Now we go on to the previous questions. One is deep sulcus line. Look at the things that I have written in black color. Deep sulcus line on a supine film. As an ICU setting, we can't make the patient to sit. In an ICU setting, in a supine film, air collects anteriorly and basally on a non-dependent portion, leading to the costophrenic angle getting abnormally deepened. Okay. If the air gets collected anteriorly basally, the costophrenic angle is going to get deepened. It will look deepened, no? That is called as a deep sulcus sign. Okay. Next question is an Ames question. Seashore sign versus pneumothorax. Repeatedly asked question. What is seashore sign? Is it normal or abnormal? Sea and shore is normal. Okay. Seashore is normal. Then barcode is abnormal. Okay. Barcode is not a natural thing. Barcode is something that we invented. It is abnormal pneumothorax. Okay. Barcode is also called as stratosphere sign. All these are seen on M mode or the motion mode of ultrasound. Okay. Seashore में waves is caused by the motionless chest above the pleural line. Okay, and whenever there is that sliding below the pleural line, it appears on USG as a sand. Okay, barcode looks just like a barcode. Motionless lines, many motionless lines makes up the barcode sign or the stratosphere sign. Now we come to the neat question. Most commonly done chest X-ray view is PA view. How do we do a PA view? We make the patient to stand and we ask them to take the maximum amount of volume possible inside lung. Full inspiration standing. PA view अच्छा है या बुरा है? अच्छा है, लेकिन थोड़ा सा बुरा है बिकॉज clavicle is seen over the lung field. So clavicle थोड़ा सा बुरा है. Clavicle is seen over the lung field obstructing our view. Then what about the scapula? Scapula is a good person. His inner border moves away from the lung field. Okay. Then ribs. PA है ना? P for posterior. Posterior ribs are more visible in PA view. What about AP view? AP view, clavicle is above the apex. Scapula inner border will be over the lung field and ribs, anterior ribs are more visible. Just iska ulta. Then next question. Middle lobe pathology. Best view is a lordotic view. Middle lobe pathology means it is right middle lobe pathology. Best view is a lordotic view. What are the other conditions where we can use this lordotic view? For apical lung pathology, middle lobe pathology or lingular pathology, you can use this lordotic view. Best view for the right lung and left lung. Okay. It is just the opposite. राइट लंग के लिए बेस्ट व्यू है लेफ्ट एंटीरियर ओब्लिक. लेफ्ट लंग के लिए बेस्ट व्यू है राइट एंटीरियर ओब्लिक. You can see in left anterior oblique everything on the left, both the ventricles, left atria, then you can also see aorta. Then left lung, right anterior oblique, you see the pulmonary artery, right ventricle and right atrium. Okay. Next is a neat question. Radiological hilum is formed by pulmonary arteries, okay, and its bifurcation, and upper lobe veins and bronchi. No lower lobe veins are involved here. Lymph nodes are visible in the hilum only when it is enlarged. Okay. What about left and right hilum? Left hilum is 2.5 cm higher than the right hilum. Next AIMS question, neat question. PCP pneumonia is a favorite question always. Okay. So PCP is pneumocystis jirovecii pneumonia. How do we diagnose? On examination of the sputum we can diagnose the case, and most sensitive is doing a bronchoscopy with bronchoalveolar lavage, and we can also see LDH getting increased in serum. What is the drug of choice? The normal antifungals, amphotericin B, is not useful for pneumocystis jirovecii, so we use trimethoprim sulfamethoxazole. IV pentamidine can be given in those patients in whom we have got a severe disease, and cotrimazole, our trimethoprim sulfamethoxazole, is not tolerating. The patient is not tolerating cotrimoxazole, and you can give IV pentamidine. Glucocorticoids can be given in PCP pneumonia if PaO2 is less than 70 mmHg or A gradient is more than or equal to 35 mmHg. Okay. Aerosolized pentamidine is an alternative in PCP prophylaxis. Okay, and it is given, prophylaxis is given when the CD4 plus count is less than 200 per microliter. Then you see recurrent candidal infection, prior PCP infection. These are the indication for PCP prophylaxis. So the next question, AIMS ka question, most common causative agent for ventilator associated pneumonia. The answer is Acinetobacter. Mechanical ventilation more than 48 hours after the intubation. पेशेंट को इंट्यूबेट किया, 2 दिन के लिए वो मैकेनिकली वेंटिलेटेड रहे और उसके बाद उन्हें वेंटिलेटर एसोसिएटेड न्यूमोनिया हो गया, तो कॉज होगा Acinetobacter. अदर कॉजेस आर स्टाफाइलोकोकस ऑरियस, स्यूडोमोनास एरिजिनोसा एंड Acinetobacter अगेन. ओके. एम्स ड्रग ऑफ चॉइस फॉर कम्युनिटी एक्वायर्ड न्यूमोनिया इन द ओपीडी. हम ओपीडी में है, कम्युनिटी एक्वायर्ड न्यूमोनिया के लिए हम क्या देंगे? Azithromycin. If the patient is previously healthy, you can safely give this macrolides like Clarithrol, Doxy, the common ones that we give. If the patient has got some comorbid medical condition or he has taken some antibiotic within last 3 months, what are you going to give? You can give respiratory fluoroquinolones. What are the respiratory fluoroquinolones? Moxifloxacin, then levofloxacin, I think. Okay, then what about, or we can give this macrolide plus something else. What is that? Beta-lactam, like moxclav, amoxicillin plus clavinic acid. Okay. If the patient has, if the community, there is increased rate of infection with increased level of MIC more than 16 and increased level of